Negrims, Shillong. Dr. Malviya, please go ahead.
Thank you very much. I thank the organizers for giving me opportunity to present my case. I believe innovations, ingenuity, and proper combination of skills is what makes a case rare and interesting. So I'll be presenting one interesting case of balloon mitral valvotomy, which I did in my lab. So I'll just start. Next slide, please. As we know, antegrade approach is a very effective and established method of doing BMV. And retrograde non-test transseptal balloon mitral valvuloplasty was developed as an alternate procedure to avoid complications of septal procedure. Retrograde approach is also very safe and efficacious, but the limitation is that it requires very special hardware. I will be discussing further what special hardwares are required. And these hardwares are usually not available in most of the cath labs centers across India. So whenever some situation arises where retrograde BMV is needed, small innovations in cath lab using routinely available hardware are the only possible way out. Next slide, please. So retrograde BMV was first described by Stefendis et al. Next slide, please. And basically, it is indicated when there is a high risk of complications during transseptal puncture, like patients with previous cardiac surgery with patch closure of ASD, or a large atrial septal aneurysm, chest wall deformity, where it may not be technically possible to do the landmarking for septal puncture, or IVC, SVC malformation or occlusion, or in cases where you have failed to do a septal puncture. Next slide, please. But the hardware required for retrograde BMV it's very rare. Actually, it was, as you can see in the top panel, it requires a special deflectable catheter, which can be deflected using the knobs at the proximal end of the catheter and give it a shape to help it enter the left atrium. And it also involves one 14 to 16 French special dual lumen balloon catheter. These two items are usually not available in cath labs across the country. Next, please. So I had a case, there was a young female which was referred from severe symptomatic rheumatoid mitral stenosis, and she had a very large atrial septal aneurysm. And the patient was not ready for open heart surgery, and we decided pre-op that there is a lot of risk in trying for septal puncture with such a large septal aneurysm. So we tried to devise a new technique to do this BMV retrogradely. Next slide, please. So as you can see here, there was a very large atrial septal aneurysm, which we thought was we will not be able to do it safely, the septal puncture. Next slide, please. So what we did was we used a simple EBU guiding catheter, which is routinely available in all cath labs for coronary angioplasty, and prolapsed it into the left ventricle in the AP view. So once it is prolapsed, we pass the guide wire along with it. And the next slide, please. And then from LV to LA, we pass the wire. Now the technique involved here is because in the original technique, there's a deflectable LA catheter. So you can direct it posteriorly and laterally, and it helps the wire to go directly into the LA. But in this case, once you use a EBU guide, it will always direct normally anatomically towards the LV outflow tract only. And all the time the wire will go back to the aorta. So the technique to direct it towards the mitral wall and left atrium, we utilize the lateral view, because in lateral view, the left atrium is the posterior structure nearer to the spine. So we gave it a twist and directed it towards the left atrium and passed the wire and made this figure of 8 shape so that the wire is stable. Next slide, please. Then we used a Tyshek balloon, 18 into 6 millimeter, positioned it across the mitral wall and inflated. Next slide, please. Next. As you can see, no, previous slide, the video. Can you play the video? No, it's previous to this. Yes. So you can see the balloon was inflated and the mitral valve opened nicely after one inflation. Then we again gave one more inflation. Next slide, please. Next. As you can see, the results of BMV was successful and acceptable. Next slide. So what are the technical considerations is the new technique we innovated in our cath lab. One is the selection of balloon size, because we cannot use the standard technique, height-based technique in selecting balloon size for these cases. So that the formula is used usually is the intercommercial distance. In our case, it was 18 millimeters. So we used the 18 mm Tyshek balloon. And the second issue is involved is once you pass a prolapse EBU guide into the LV and try to pass the wire, you can always go through the submitral apparatus and then go into the LA. So while taking up your balloon, you might injure the submitral apparatus. To ensure that there is no wire entry through the submitral apparatus, we used a Swan-Ganz catheter, semi-inflated, to see the free flow of the catheter so that no submitral apparatus is injured. And as I discussed the angiographic views, lateral view is the most important view for this technique. Next slide, please. So the take-home message from this case is that retrograde BMV is useful technique where risk of complications during transseptal puncture, normal antegrade BMV is very high. And in our technique, the special hardware is not required. We can use all hardware which are routinely available in cath lab. The arterial access is only 8 French, which is for the Tyshek balloon, compared to 16 French access required in the conventional retrograde technique. And it is a simple and safe and low cost technique. Next slide, please. I think it's done. Thank you so much.
Thank you, Dr. Malviya. Wonderful presentation.